And now it is my pleasure to invite my best friend from Cairo University, Professor Mona Amin, and her talk today will be hepatitis D from virology to new therapy. Mona?
Good morning, everybody. You hear my voice clearly?
Yes.
Yes, we
Yes,
can
it's
hear
very
you.
good.
Okay. Thank you very much for the invitation to participate in your wonderful meeting. My dear Professor Carming as the Romanian Society of Internal Medicine. My topic today is hepatitis D from virology to new therapies. This is first my disclosure. My agenda today will cover hepatitis D epidemiology, virological and clinical aspect, current management, and review data from recently completed studies and outline of upcoming trials evaluating novel therapy. This is the global distribution of hepatitis delta as published by the CDC. And here we can see the hotspots with the highest rate of D prevalence in hepatitis surface antigen positive patients, which may reach in Mongolia, for example, 80% compared to the normal prevalence in 5% of cases of hepatitis surface antigen positive, we find positivity of hepatitis D. And a recent meta-analysis proposing that struggling 62 to 72 million people may live with hepatitis D worldwide. Actually, you have 8 genotypes, with genotype 1 globally distributed and genotype 2 to 8 have a distinct geographic location. For example, genotype 3 is mainly identified in South America, while genotype 2 and 4 are mainly found in East Asia. And from 5 to 8 are mainly found in Africa. Chronic hepatitis D is arguably the most aggressive type of viral hepatitis and is associated with increased risk of cirrhosis, decompensation, and hepatocellular carcinoma. About 70 to 80% of hepatitis delta develop cirrhosis in 5 to 10 years. In contrast to hepatitis D, which is about 20% of the patients over 5 years. And hepatitis C develop cirrhosis in 20% of cases in over 20 years duration. Hepatitis delta is transmitted by the same way as hepatitis B, mainly parenteral. And intravenous drug abusers is the main route of transmission. Hepatitis delta is a deficient virus. It is the smallest RNA virus, and it is dependent on hepatitis B for its packaging, and also depends on the host RNA polymerase for its replication. Being a defective virus dependent on hepatitis B, so it either occurs as a simultaneous co-infection with hepatitis B, which is more likely to have fulminant hepatitis, but recovery is zero in more than 95% of the cases. Or it occurs as a super infection on top of chronic hepatitis B, where chronicity is zero in more than 95% of the cases, and more severe course of the disease occur. Both hepatitis B and hepatitis D use the different surface antigen protein, the small, medium, and large surface antigen for their assembly. And actually, hepatitis D has one open reading frame. Hepatitis D antigen is encoded in 2 isoforms within the hepatitis delta genome. The small one, which is formed of 195 amino acid, and the large antigen formed of 214 amino acids. While surface antigen initiate and maintain replication, the large antigen has a negative effect on replication and trigger the envelopment of the virus within the hepatitis surface antigen. And both antigen, small and large, undergo post-translational modification in order to fulfill this distinct function. The large antigen undergoes prenylation by the farnesyl transferase enzyme, adding prenylation to the large antigen within the C-terminal domain at position number 211. And upon this, the prenylated large antigen is able to recognize the hydrophobic element within the small surface antigen to become assemblant. So if we have a look on the life cycle of the virus, the complete virus attach first to the sodium, to the heparin sulfate protoglycan, but it enters through the same entry receptor for the hepatitis B, which is the sodium taurocolate, and after binding fusion with the membrane by an unknown mechanism, it enters into the cell with release of the ribonucleoprotein that enter into the nucleus, where a double rolling circle amplification mechanism generating polymeric antigenomic and the genomic RNA. And the genomic RNA is the template for the messenger RNA translation of the two isoforms of the antigen, the small and large. Part of the large antigen undergoes prenylation with the farnesyl transferase to be able to attach with the surface antigen produced by the covalent circular DNA or integrated DNA, and after packaging, it is secreted by the classic secretory pathways to infect other cells. So hepatitis delta spread by two main pathways, and each pathway has its target of antiviral. The first pathway, which is the extracellular spread, the nouveau infection, which is dependent on the presence of surface antigen on the cell and occurs through the interaction with the sodium taurocolate receptor, and so it can be inhibited by targets of entry inhibitor, Hepaclodex, or prevention of prenylation of the large antigen to inhibit assembly of the virus, as well as interferon. Also, the product of replication of the virus can be transmitted during mitosis, and this is independent of the surface antigen and can be modulated again by interferon. So this figure illustrates the two ways of spread of hepatitis delta, the de novo infection as well as during cell division. So you may need to give an inhibitor of de novo infection and the inhibitor of cell division. The current treatment, actually until 2020, there was no approved treatment for chronic delta, no impact of nucleoside analog as it uses the host polymerase. Pegylated interferon, it is not FDA or EMA approved for hepatitis delta, but it is either the standard interferon or big interferon is widely used over the last 30 years for the treatment of pegylated interferon. And although big interferon is recommended by most of the international guidelines, in clinical practice, it is not much used because of the significant side effect, the limited efficacy. Patients with advanced disease are not eligible for the treatment, and the high long-term relapse rate. And when used with adenovirus for 48 weeks and with tenofovir for 96 weeks, no additional significant post-end of therapy treatment response. Actually, is sustained virological response visible with interferon alpha the two biggest studies evaluating interferon alpha for hepatitis delta showing a response rate only in 28 and 27 in the other study, end of treatment and 6 months after end of treatment, negative PCR for hepatitis delta. But actually 56% of these patients relapsed on longer term follow-up. So the novel therapy in clinical trials, as I said, big interferon is not, it is off-label indication. It is approved for hepatitis B. Lambda interferon is in phase 2 study. The entry inhibitor, Hepaclodex or Bervertide, which is approved in July 2020 by EMA as a treatment for hepatitis delta, and it is now in phase 3 trial. LONAfarnib, which is inhibiting the granulation of the large antigen and so inhibiting the assembly of the virus with the surface antigen, is in phase 3 trial now. And nucleic acid polymers, which block the secretion of surface antigen and consequently prevent the release of hepatitis B and D, are in phase 2. Myrcludex, as I said, it is an entry inhibitor. It blocks the sodium taurocolate receptor, preventing the entry of both hepatitis B and hepatitis D. And in this study, which is Myrcludex 202 study, that was to determine the safety and tolerability of 6 months treatment of Myrcludex and to study the antiviral efficacy of Myrcludex in hepatitis delta, and to determine the optimal dose of Myrcludex for hepatitis delta, where treatment in different doses was evaluated versus tenofovir for 6 months and followed up for another 6 months. Actually, all doses have hepatitis delta RNA decline with all doses compared to tenofovir, and about 77% achieve more than 2 log reduction in the RNA or RNA below the detection level with the high doses. And also the liver enzymes decreased with the all doses compared to tenofovir, and 50% of the cases has normalization of the liver enzyme at the end of treatment. Also, the liver stiffness values as detected by FibroScan improved with the 10 milligram Myrcludex versus tenofovir. And actually the drug was safe, and the bile salt elevations that occurred with its use has no clinical consequences. So the Myrcludex phase 203 end of study results, which was investigating different doses of Myrcludex plus big interferon for 1 year and follow up the end of response 6 months after the end of therapy, the undetectability of RNA of the Delta virus. And they detected that 50% overall has undetectable RNA compared to 13% with interferon monotherapy. And the log reduction was 4.4 log reduction more than the interferon, which is 1.1. And the combo shows improved efficacy and induce a cure in a subset of patients. Then the Myrcludex extension of 203 study, which is a multi-center, open-label, randomized, comparative, active control phase 2 study, evaluating a 10 milligram dose in addition to big interferon and 10 milligram in addition to tenofovir compared to tenofovir, the drug alone. And the 10 milligram monotherapy was safe and more suitable for maintenance therapy. And as shown in the lower doses, strong synergism, the addition of interferon increased too much the response, and no advantage of the high dose in surface antigen response over the lower dose. So this is the ongoing phase 3 study of the Hepaclodex in patients with chronic delta, which is Myrcludex 301, which is multi-center, open label, randomized for 3 to assess the efficacy and safety of Hepaclodex in chronic delta used for 144 weeks. 150 patients will be randomized to 3 different arms using different doses and followed up for 96 weeks, with the total duration of the study 240 weeks. And the primary endpoint is the undetectability of the hepatitis D RNA or decrease more than 2 log, and normalization of liver enzymes. In the last EASL International Liver Congress 2021, 3 cases of liver cirrhosis and portal hypertension related to hepatitis delta using 10 milligram self-administered in addition to Nucleic for B was used for 3 years, and they concluded that continuous administration of Belvertit for 3 years provide excellent virological and clinical response in hepatitis delta cirrhotic patient with clinically significant portal hypertension. The second drug, which is LONAfarnib, which is a farnesyl transferase inhibitor, preventing the farnesylation of the large antigen of the virus and consequently its interaction with the surface antigen and abrogates the secretion of the hepatitis B viral particles. And in the proof of concept, the trial, where the LONAfarnib used in 14 patients, published in 2015, those who use the drug have a reduction on the viral load compared to placebo, and the reduction was proportional to the serum drug level. But this was associated with significant side effects, mainly gastrointestinal. So the LOWR HD program, which depends on the Ritona use with the LONAfarnib, as the Ritona is a cytochrome inhibitor, leading to the use of smaller doses of LONAfarnib with achievement of a high drug level with a small dose, and so decrease the side effect of LONAfarnib large doses. And it is studied in this 4 program: LOWR1, which is LONA with Ritona in hepatitis delta, to assess the tolerability and viral response of different doses of LONA as monotherapy or in combination with Ritona or big interferon, with the primary endpoint the decline in the RNA between baseline and end of treatment, either 8 or 12 weeks. And they showed that combo therapy has significant viral decline and normalization of liver enzymes with much improved GI tolerance. The LOWR2 study, which is dose-finding study. Dose-finding study to identify the optimal combination regimen of LONA, Ritona, interferon, which demonstrate efficacy and tolerability for long-term dosing to enable clearance of the virus. And they concluded that LONA 25 milligram twice daily plus Ritona 100 milligram and the big interferon lead to the most rapid and profound decline in the viral load. 60% become PCR negative at end of 6 months, and 100% achieve hepatitis delta RNA below the detection level. And dosing more than 6 months may improve the outcome as regard negativity of the PCR. And the adverse effect was mainly grade 1 GI side effect. The LOWR3, which is once daily dosing study, it was to assess the antiviral effect and safety of once daily Ritona boosted LONA in patients with chronic D. And they confirmed that the drug is safe and generally well tolerated, with lower viral load at the end of 12 and 24 weeks of treatment. And they projected by remodeling that increasing the duration of the study may lead to clearance of the virus in a subset of patients. The LOWR4, which is dose escalating study to investigate the dose escalation or maintenance up to 100 milligram twice daily of LONA plus Ritona for 6 months. And the study confirmed the antiviral efficacy of LONA over 24 weeks, and off therapy control of RNA is possible in a proportion of patients. Long-term therapy and combination therapy need to be explored. So overall, the LOWR study demonstrated that the combination of LONA-Ritona, which all oral therapy, achieve a reduction of the viral load in about 39% and normalization of the liver enzymes in up to 60%. When interferon is added, the RNA decline reach up to 89%, and the normalization of the liver enzymes reach more than 75% of these patients. This gives the rationale for the ongoing phase 3 study, DLIVR, which is Delta Liver Improvement and Virologic Response in Hepatitis Delta, where 400 patients will be randomized to different doses of LONA 500 milligram and 100 milligram, with the primary endpoint more than 2 log reduction in the RNA and normalization of the liver enzyme at the end of 1 year treatment. Pegylated interferon lambda, which is a novel first-in-class 3 interferon, it binds to a unique receptor versus type 1 interferon, which is highly expressed on the hepatocyte, with limited expression on the hematopoietic cells and CNS cells, with comparable antiviral activity and less of the typical alpha interferon related side effect. The LIMT study, which is phase 2 Lambda study, open label randomized of the 120 milligram and 180 milligram once weekly, used for 1 year and followed up 6 months after the end of therapy to evaluate the tolerability and safety. And they found that they have a durable virologic response of lambda, durable, that is 6 months after the end of therapy, in 36%, which compare favorably to the historic rate of alpha interferon, 28%, but better tolerability than the alpha interferon. Actually, 10% of patients developed hyperbilirubinemia and elevation of liver enzymes, which improved with decreasing the dose of the interferon and with no signs of decompensation. Then studying the lambda interferon in addition to LONA 50 milligram and Ritona 100 milligram for 24 weeks, which is studied in phase 2 open label study on 26 patients with chronic delta, which is left study. And they concluded that therapy with this triple combination was relatively safe in most patients up to 6 months. And after 24 weeks of therapy, almost all patients has more than 2 log reduction in the viral load, and 85% has undetectable or RNA below the lower level of detection. And the side effect mainly was grade 1 gastrointestinal, and mainly due to the interferon in this triple therapy, which lead to discontinuation of the therapy in 15% of the cases and reduction of the dose in 11% of participants. The last drug, which is the nucleic acid polymer, or the REP 2139, as I said, nucleic acid polymer, it prevents the release of surface antigen, and so it decreases the release of both hepatitis B and hepatitis D from the cell. And this study on the REP 2139 calcium, in addition to Pegasys or interferon combination, the drug was used as an intravenous injection of 500 milligram once weekly for 15 weeks, followed by combination with big interferon 180 once weekly plus 250 of the drug for another 15 weeks. Then 33 weeks of big interferon monotherapy with a total duration of 63 weeks of the study. And at the end of combination, 83% have RNA negative, and the surface antigen dropped in more than 75% to more than 2 log reduction in the surface antigen, even before the start of decline, even before the addition of interferon. And 18 months after the end of the therapy, 7 out of 12 patients still negative for the Delta PCR, and 4 out of 12 still seroconverted as regard surface antigen, which is maintained 1 year after end of therapy. And when this same patient followed up for 3.5 years of follow-up, still there is a response rate in 7 out of 11 as regards the RNA, also in the surface antigen response and the clinical response for 3 years post follow-up. And this is the ongoing study on the REP 2139 magnesium IV versus sub-Q in patient with Delta co-infection. It is ongoing to assess the safety and tolerability of this drug, as well as with the endpoint surface antigen and hepatitis RNA loss during therapy, surface antigen seroconversion, L-transaminase flare, functional cure for B and D 6 months after cessation of treatment. And so my take-home message, 40 years after the discovery of hepatitis delta, the first drug approved in Europe now is the beginning of a new era for this difficult to treat and cure patient, and deeper understanding of the virological and immunological mechanisms contributing to viral control will help to advance on the road to hepatitis delta eradication. And thank you very much.